طيب, let's get into the main topic. Ischemic stroke is very common. It's one of the most common cause of inpatient neurology admission. It's the second leading cause of death globally after cancer and heart disease. It's the leading cause of disability in elderly patients. And it's a major economic burden on in any country. So it's a major cause of death. It's the leading cause of disability in elderly patients, and it has a major economic impact. That's why we need to take these patients seriously. And it's actually acute ischemic stroke management is now on top of the healthcare issues in Vision 2030 of Saudi, in addition to cancer and heart disease. Okay, so in terms of risk factors, we usually think about it as modifiable risk factors and non-modifiable. Non-modifiable can include age, because you cannot change age, your genetics, family history, the presence of an underlying blood disorder, whether it's because of genetic thrombophilia or acquired thrombophilia, such as cancer. In regards to modifiable risk factors, the most common ones is hypertension. And so basically, hypertension is the most common risk factors for strokes. To understand the impact of hypertension on the development of stroke, if you take one patient with hypertension and cut his systolic blood pressure by 10, يعني assuming this patient systolic blood pressure is 150, if you drop this blood pressure, systolic blood pressure, down to 140, you reduce the relative risk of future stroke by 40%. Dropping the systolic blood pressure by 10 millimeter mercury can drop your relative risk of developing future stroke by 30 to 40%. واضح? So it's a major impact. What's the second most common cause for developing strokes after hypertension? What do you guys think? خلينا نشوف لما تقول diabetes، مبارك يقول AFib، عزيزة، Juri. Okay, so just to cut it short, I don't want to waste your time. The second most common cause or risk factor for developing strokes is smoking. Okay, diabetes is a funny risk factors, because diabetes. So if someone was diagnosed with diabetes, okay, their risk of stroke goes up. Okay, however, if you control diabetes and you controlled A1C, their stroke risk does not necessarily go down, because diabetes causes stroke in two different ways. One, it can cause small vessel disease, and it causes large artery atherosclerosis. So you can control, if you control your A1C, you can reduce your large artery atherosclerosis risk. However, your small vessel disease risk is still the same. في واحد بيسأل بيقول the stroke common or the MI because of hypertension. ما فهمت السؤال. Which one is more common؟ هذا سؤالك؟ MI or stroke؟ محمد. Cardiac disease is way more common. So cardiac disease, then strokes. Okay. طيب. Then cardioembolic cause, whether it's atrial fibrillation. طبعا atrial fibrillation is the most common cause of cardioembolic strokes. Cardiomyopathy or heart failure. It's one of the modifiable risk factors. Obesity, drugs such as hormonal therapy, they're all considered modifiable risk factors. طيب, when you think of the general theme, how do you classify the causes of ischemic strokes, the etiologies? So the major theme is, and this is how I think about it, large artery to artery embolus, cardioembolic strokes, thrombophilia, and cryptogenic. Okay? These are the most common ones. Artery to artery embolus, واحد عنده carotid artery disease causing narrowing that is significant. This narrowing is because of a plaque. When the plaque ruptures, it can cause clots to form, and these clots can travel to the brain. Cardioembolic cause, the most common one is atrial fibrillation, but it's not the only cause, because endocarditis is a cause, cardiomyopathy, valvular heart disease, all these are causes of cardioembolic stroke. The third type, it is small vessel disease, and we see this in patients with chronic hypertension, diabetes, and smoking. And the pathologic process that happens in small vessel disease is called lipohyalinosis. And this is very hard to control unless you basically bring down the blood pressure to normal, control dyslipidemia, stop smoking, and so forth. Systemic hyperperfusion, I would say this is not a very common cause. We see this patient, we think of this mechanism in patients who are inpatients, who are undergoing surgeries, or they had a systemic disease that causes hyperperfusion, such as sepsis or bleeding, but it's not very common. The last category, which is the cryptogenic stroke. So these are the patients who are admitted to the hospital with acute ischemic strokes, but they don't have vascular risk factors. They don't have vascular stenosis. Their cardiac workup is negative, and there's no apparent cause. So this is called a cryptogenic stroke. طيب. طيب. I'm going to talk real quick about the etiology of hemorrhagic stroke, just because the slides is here. If you think about stroke in general, 80% of all strokes are ischemic, 85%. 10% are intracerebral hemorrhage, and 5% are because of subarachnoid hemorrhage. When it comes to intracerebral hemorrhage, the most common cause for intracerebral hemorrhage is hypertension. And hypertensive hemorrhage usually has a location predilection. It usually happens in basal ganglia, mainly putamen, caudate, thalamus, pons, and cerebellum. واضح؟ Other causes of intracranial hemorrhage is hemorrhagic conversion of an ischemia, drug-related, such as anticoagulant, vasculopathy-related, such as vasculopathy we see with methamphetamine use, cocaine use, or RCVS, reversible vasoconstriction syndrome, patients with bleeding diathesis, such as hemophilia or thrombocytopenia, amyloid angiopathy that we see in elderly, and usually these are bleeding that happens in the cerebral cortical region. We call it lobar hemorrhage, vascular malformation, metastasis or brain tumor, brain cancer, or trauma. And the reason patients develop subarachnoid hemorrhage, the most common cause is ruptured intracranial aneurysm. Less second in terms of causes would be vascular malformation, whether it's AVM, AV fistula, cavernomas, and last but not least, trauma. Usually when we have patients presenting with acute deficit, usually we think of stroke, and this is reasonable. However, you always have to consider the non-vascular causes of acute deficit. You have to rule out stroke mimics, such as seizures, migraine with aura, metabolic disturbance such as hypoglycemia, subdural hematoma, functional disorders, drug-related side effects. صوتي واضح؟ طيب تمام. طيب. So now let's get into the real business. How do we use everything we said? How do we use our basic knowledge of neuroanatomy, vascular anatomy, and how do we translate this into clinical practice? And this is what makes this is what the main point of this talk. So if you have a patient presenting into the ER, 65-year-old man who presented with vision loss in the right eye that lasted 5 minutes. He came into the emergency room. The emergency room doctor did his initial checkups. He ordered a CT scan, got an ECG, did the basic lab work, and he called you. Doctor, salam alaikum. We have a patient, 65-year-old with 5 minutes vision loss in the right eye. How do you approach this patient? How do you approach? What do you think is happening? You are in the ER seeing this patient. Before we get a CT scan, what do you think is happening? Do you think that this is a stroke? Do you think this is an ischemic stroke? Do you think this is a hemorrhagic stroke? Okay. طيب ممتاز. So what makes the distinction between ischemic stroke or hemorrhagic stroke or TIA? Exactly. So as I said, this patient said he had 5 minutes of vision loss in the right eye, which means that the symptoms when he presented to the emergency room is already gone. And you can confirm this by performing a physical exam. So your physical exam should confirm your history. So if your history suggested that the patient had vision loss that resolved after 5 minutes, and your clinical exam confirmed this finding, then this patient has transient ischemic attack. واضح? However, if the patient said, I had 10 minutes of right-sided weakness, and then it resolved. However, on your clinical exam, you can see a mild drift. What do you call this now? Do you still call it TIA? It's not a TIA anymore. Why? Despite the patient telling you that his strength is back to normal, your exam did not confirm your history. Your exam is different than what the patient is saying. So the patient says, I had weakness in my right side for 10 minutes and it's resolved. However, when you do your exam, you notice that the patient has mild right-sided drift in his arm. So it means this weakness did not actually completely resolve. So you're dealing with a stroke. Okay? طيب. This is different than someone who comes into the emergency room with right-sided weakness. Okay? And he says, the patient says, or she says, well, this weakness has been there for like 30 minutes. You examine the patient, your exam confirmed the patient's history. Now, what do you call this? What do you call this? When someone, exactly, stroke. Because the patient is telling you, I've been having weakness for the past 30 minutes, and it's still there, and your exam, you can tell that the patient has right-sided weakness. So you call this a stroke until proven otherwise. طيب. You send the patient for a CT scan. The patient comes back and he says, you know what, doctor, my weakness has resolved. So you re-examine the patient again, and the patient has no weakness at all, no drift even. What do you call this? TIA, أحسنت. So the point of what I'm saying now, in all these clinical scenarios, stroke and TIA are clinical diagnosis. A patient can present with TIA by history, but the exam disagree. Patient can present with an acute weakness that you can confirm on exam, but the patient, by the time comes back from a test, the weakness is resolved. So now the diagnosis is changed from a stroke to TIA. Okay? So TIA and strokes are clinical diagnosis. واضح؟ In each case, if you believe that the patient is having symptoms, and these symptoms are within 24 hours, you should immediately activate stroke code. You guys agree? If the patient presented with acute deficit and the patient is within 24 hours, you should activate the stroke code. Okay? Right. Let's talk about the first clinical scenario. 65-year-old man presented with vision loss involving the right eye for 5 minutes, and that vision loss is completely resolved. What's your diagnosis? Okay, TIA. But this patient is in the ER. You're seeing this patient, you're taking history, you're doing your physical exam. The history is as follows. The patient says, I was watching TV, we had lunch, I sat down, I was watching TV, and all of a sudden, I can feel that there's almost a curtain coming down on my right eye until I lost the vision in the right eye completely. And then after 5 minutes, I started gradually regain my vision in the right eye. Okay? I do my physical exam in the ER, and his exam is completely normal. What would you do in this case scenario? Okay, so your diagnosis is TIA because his symptoms are transient and his exam is completely normal. What would you do in this case scenario? Okay, so you do your basic approach. So you make sure that A, B, C, D are covered. You make sure the patient is stable, connected to monitor. All right, send basic labs, get an ECG, chest X-ray, and then immediately get a CT scan because you want to make sure that there's no mimics for TIA. You want to make sure that the patient did not have a tumor caused him to have a seizure. The patient did not have subdural hematoma that can mimic a stroke or TIA. All right? So you want to rule out any stroke mimics or hemorrhage. Alas, if your CT scan is completely normal now, what would you do? Would you send the patient home? Would you admit the patient? What do you do? How do you deal with TIA? How do you approach TIA? Okay, so I see you guys are some of you are saying start antiplatelets. Some of you guys says admit for investigation. Some people say do an MRI. Some people say do ABCD2 score. But the way we should look at TIA is TIA is a warning sign for an impending stroke. بمعنى إنه we should deal with TIA as if it's a stroke. Because if the patient was lucky enough this time and his symptom was transient, in 2 days, this patient could have a major stroke that could kill him. So we should take TIA very seriously. طيب. Should we treat and deal with all TIA's patients in the same way? No. There's high-risk TIA and there's a low-risk TIA. And how do I decide which one is high risk or low risk? We use the ABCD2 score. This score can roughly tell me that you're dealing with high risk TIA versus low risk TIA. And what does it mean, high risk versus low risk? High risk TIA means that the patient's risk to have a stroke over the next 2 days is 8% if it's high risk versus 1% if it's a low risk. واضح? If it's a high risk TIA, the recommendation says you have to admit the patient immediately for 2 reasons. 1, to observe if the patient developed a stroke, so you can treat it accordingly. 2, to perform the workup as soon as possible. If the patient has a low-risk TIA, you can actually discharge the patient from the ER after giving and prescribing antiplatelets and statin therapy. Ask the patient to come back the next day to do the workup as an outpatient. Okay? طيب. The problem is in the ABCD2 score. طيب. What are the items, just to understand that you guys are on the same page with me? What are the items of the ABCD2 score? What is there in the items that decide whether the patient is high risk or low risk? Age, blood pressure, إيش كمان? Diabetes, duration of what? Duration of what? Of symptoms. Okay? The type of symptoms. What kind? Is it sensory symptoms? Is it language? Is it weakness? واضح؟ طيب. If I told you that this patient was diagnosed with new onset atrial fibrillation in the ER, this patient has TIA, you do your ECG and you find out that he has atrial fibrillation, what do you think? Or this patient says, this patient who has TIA, transient vision loss, told you that he did have a Doppler scan of his carotids, and the doctor who did the ultrasound told him that you have a significant stenosis of the carotid artery on the right. What do you think? Right. If I told you that this patient has a very low ABCD score, but he has known carotid artery stenosis, do you still consider this as low ABCD or low risk TIA? Exactly. So the point I'm trying to make is the ABCD2 score is good in giving you an idea whether this is a high risk or low risk stroke or TIA. However, it doesn't incorporate major risk factors such as the presence of atrial fibrillation, the presence of carotid artery disease, the presence of thrombophilia. So the patient can have low risk TIA based on ABCD2 score, but the presence of carotid artery disease can make him high risk. واضحة الفكرة؟ طيب. So from a practical point of view, in most hospitals هنا في مكة, we don't have stroke clinic. The recommendation says, if you discharge a TIA patient because he or she is a low risk TIA, that does not mean the patient can be seen as an outpatient in 1 week. You should complete the workup within 48 hours. So in hospitals like our hospitals in Mecca, we cannot see the patient as an outpatient within 24 or 48 hours. So what I usually do, I usually admit all TIA patients as if they are stroke patients. Because my worry is if I discharge low risk TIA patients, they're not going to come back to me to be worked up within 48 hours. وضحت الفكرة؟ If I have a stroke clinic ready to see patients coming back from the emergency room, I would discharge low-risk TIA patients. I would give them aspirin and statin, and I ask them to come back tomorrow morning to be seen in the stroke clinic. But if I don't have stroke clinic ready, I usually admit these patients and conduct a full workup. محمد عطية، ما فهمت سؤالك. افتح المايك واسأل عادي.
السلام عليكم، الله
عليكم
يحفظك.
السلام.
ليش احنا ما نقدر في مكة انه نشوفهم خلال 24 ساعة ل 42 ساعة؟ بس هذا هو كان سؤالي.
طيب احنا يعني المستشفيات عندنا في مكة we don't have the capacity to have stroke clinics 3 or 4 times a week. We don't have the manpower, we don't have the physical space. That's why what I do is admit all these patients to be worked up as an inpatient. Because if I say you are discharged from clinic, the only time, the earliest possible appointment is to come see me in clinic in 1 week time. But this is not acceptable because the guideline says you have to conduct full workup for all TIA patients within 24 to 48 hours. وضحت الفكرة؟ في ريماس تسأل دكتور لو عندي patient with TIA results مو نبدأ ب MRI or detect ischemia and we can detect it by CT. طيب احنا حنسوي CT scan as I said to rule out hemorrhage and stroke mimics. But if the CT scan is normal and the history confirms that the patient's symptoms resolved and the exam is normal, so this confirms that this is TIA. TIA should be worked up as if the patient had a stroke. واضح؟
دكتور
وضحت الفكرة؟
بالنسبة
عفواً؟
للبيشنت اللي ممكن أيوة. واضح، بس بالنسبة للبيشنت اللي ممكن يكون عندهم مرجك ممكن يكون عندهم ريزولف للسيمتومز.
Yes, subdural hematoma can mimic and can cause TIA. I've seen patients with subdural hemorrhage presenting with TIA. And this is a good point that we bring this up because TIA sometimes be explained by hemorrhage. So the point is, the clinical significance of this is that when patients have TIA at home, I don't suggest taking aspirin because this is a common practice. We see this all the time. والله دكتور جاني weakness لمدة 5 دقائق وراح قمت أخذت أسبرين على طول. This is a very wrong practice because what if the symptoms were because of cerebral microbleeds or subdural hematoma? You're going to make things worse. You always have to have a CT scan before you do this. Always. I don't start antiplatelets before doing a CAT scan. واضح؟
واضح دكتور.
Okay. طيب. طيب. For TIA patients, what workup should we conduct? If you decided that this is TIA, history, physical exam confirms it, CT scan is negative, what workup you would do? Okay, طيب ممتاز. To summarize, the workup I'm going to conduct in TIA patients, I usually think of all the mechanism of ischemia that we discussed a slide ago. So we talked about carotid artery disease, then I have to do vascular imaging. I need to check, does this patient have carotid artery disease? 2, I have to do complete cardiac workup, which include echo and Holter. Why Holter? Because some patients have paroxysmal AFib. Paroxysmal AFib يعني AFib that comes and goes. طيب في واحد ممكن يسأل يقول طيب why do we even look for paroxysmal AFib? The answer is paroxysmal AFib can put the patient for a risk of cardioembolism. Even if it's paroxysmal, there is a risk of cardioembolic stroke because of paroxysmal AFib. طيب, so vascular imaging to look for carotid artery disease, vascular imaging to look for intracranial atherosclerotic disease, يعني atherosclerosis involving the arteries of the circulus Willis. 3, cardiac workup, echo, Holter, and the echo can be transthoracic or transesophageal. If the patient is young, I would add thrombophilia workup or autoimmune workup. واضح? If there is nothing panned out, I would put the patient on antiplatelet, statin, and then 3 months later, I can repeat the workup to see if I didn't catch something in the first time. I can repeat it later on, especially the Holter. And I can follow up the thrombophilia workup as an outpatient. You don't need to keep the patient for 2 weeks to look for, to wait for the thrombophilia workup. طيب, if the workup showed carotid artery stenosis, that is critical. The definition of critical carotid artery stenosis is a stenosis that is greater than 70%. Then you have to send the patient for carotid revascularization, whether by surgery, carotid endarterectomy, or stenting. So you would put the patient on aspirin, send the patient for carotid artery stenting, and then follow him up in clinic. But if in your workup you found out that the patient has atrial fibrillation or intracardiac thrombus, you would stop the antiplatelet, put the patient on anticoagulation. Okay? If the patient had normal carotid arteries, normal cardiac workup, however, you found out that the patient has thrombophilia, you would put the patient on anticoagulation. وضحت الفكرة? So basically, your workup is targeted through the underlying mechanism. Once you find a mechanism, then you treat that mechanism. وضحت؟ تمام. طيب. Let's shift gears towards acute ischemic stroke treatment. طيب. As I said, TIA and stroke treatment are the same in terms of the goal of secondary prevention. However, if you have a patient who presented to you in the ER with acute deficit, your goal, your immediate goal is not secondary prevention. صحيح? What's your goal in treating acute, hyperacute stroke treatment? What's the goal? So in TIA patients, the goal is secondary prevention, is to prevent this from happening again. But when you have someone presenting with an acute deficit that is still not resolved, your goal is not secondary prevention. Your goal is reperfusion. أحسنتم. However, the steps, your approach is still the same. You would take focused history, focused clinical exam, and then focused workup. So let's start with focused history. What's the important historical facts you would ask about in patient with acute neurologic deficit? Okay, so onset of symptoms or last known well. طيب. Quick description of the patient symptomatology. All right, and quick screening for the contraindication for thrombolytic therapy. These are the three main categories. So last known well, description of patient symptoms and the underlying risk factors, and then quick screening for contraindication for thrombolytic therapy. واضح? This is when it comes to history. طب your physical exam is basically directed. If you believe that this patient has a stroke, your physical exam should be focused and directed. And we usually use the NIH stroke scale, which is mentioned in here. The NIH stroke scale, it's basically a scoring system that quantifies the severity of the stroke. So when you tell me that this patient has a stroke scale of 4, I understand this is a minor stroke. If it's 10, it's moderate. If it's above 10 or 15, it's moderate to severe. And the reason why we do use NIH stroke scale is for 2 reasons. One is to quantify the deficit. Number 2 is to predict the presence of large vessel occlusion. واضح? So واحد, to quantify the deficit. And so what's the point of quantifying the deficit? Any idea? Why do we need to quantify the deficit? Okay, so follow up. Because you can tell if the patient is improved أو لا depending on his stroke scale. يعني مريض أول ما يجيك stroke scale 15, you offer treatment. You offer the treatment, and then upon discharge, stroke scale goes down to 4. So now you can tell that the patient improved. Or the patient has NIH stroke scale of 15, you give him thrombolytic therapy, you admit the patient to the ICU, the patient gets worse, stroke scale is now 25. Now you're thinking that the stroke scale is worse, you have to think of bleeding. Yes, you can do NIH stroke scale in the OPD if you want. But usually we use it in the acute settings. في الOPD عادة في الacute settings أو في الinpatients. في الOPD we use the MRS score اللي هو modified Rankin scale. Okay? Just a second if you don't mind. Okay. If he was lastly well before sleep, how could I calculate the time? طيب. The reason we talk about last known well, as you guys know, is to determine whether the patient is within the window of treatment ولا لا. عندنا reperfusion therapy نوعين. IV thrombolytic therapy or mechanical thrombectomy. عندنا stroke treatment reperfusion therapy in stroke عادة time sensitive. So far for IV thrombolytics we usually use the cutoff of 4.5 hours, and for mechanical thrombectomy we use 24 hours. Things could change in the future. طيب. Why do we ask about the last known well rather than the onset of symptoms is because of wake up strokes. زي ما محمد الحارثي قال الناس اللي يصحوا من النوم with stroke symptoms we cannot consider the onset of symptoms من يوم ما صحي. لازم نقول متى آخر مرة المريض كان كويس. ففي الويك اب ستروكس ما نبدأ التايم ويندو حقنا من الانست اوف his wakefulness. نرجع لآخر مرة كان كويس قبل لا ينام الساعة 10 في الليل مثلا، هو صحي الساعة 5 الفجر عنده right sided weakness. We don't start the clock من هنا من 5. نقول له متى آخر مرة يا عمي كنت كويس؟ والله آخر مرة قبل لا أنام الساعة 11. خلاص last known will 11 o'clock. واضح؟ And the reason why we do this is because we want to avoid complications. We don't want the patients to bleed, because if the patient had a stroke symptoms for a long time, this can put the patient at risk of hemorrhagic conversion. واضح؟ طيب. So after your focused history, after your clinical exam, then what? What do we do? This patient is in the resuscitation bay in the ER. أحسنت يا علي. أحسنت يا ريماس. Immediately we should get, after stabilizing the patient, connecting him or her to a monitor, get an ECG, basic blood work. Right? We should immediately get a CT scan because you want to rule out hemorrhage and stroke mimics. And if the CT scan is negative for hemorrhage or stroke mimics, you want to quantify the amount of ischemia. Do we see any early signs of ischemia ولا لا؟ واضح؟ If the patient forgot the symptoms onset or he's not sure, then he's outside the window of TPA. نسأله متى آخر مرة كنت كويس؟ متى آخر مرة تتذكر إنك كنت كويس؟ هو السؤال كده. واضح؟ طيب. I'm gonna take 2 minutes and I'll be back. Let's take 2 minutes break and I'll be back in 2 minutes, okay? I apologize. Okay, so let's go back. Okay, so focus history, focus exam, then immediate CT scan to rule out any stroke mimics, hemorrhage. And then what? What do you guys want to do? Right. The classic teaching, so CTA is not wrong. The classic teaching, if the patient presented within 4.5 hours with acute neurologic deficit, and the patient is above 18 and has no contraindication for TPA or thrombolytic therapy, you should start IV thrombolytics immediately. And then get a CT angiogram. واضح؟ In some places, in order for you to get a CT scan, then bring the patient back to ER and then get a CT angio, usually it takes a long time. In that situation, we usually do CT angio. But the classic teaching, you do your CT scan. If the patient presented within 4.5 hours, no contraindication TPA, you start thrombolytics. Then you get CT angio. تمام؟ طيب. If you did your CT angio and the CT angio showed large vessel occlusion, what would you do? TPA, mechanical thrombectomy. طيب. Mechanical thrombectomy. طيب. According to the recent guidelines, okay, if someone presented within 24 hours with acute neurologic deficit, CT scan was negative for hemorrhage or any stroke mimics, and the patient had large vessel occlusion, these patients are candidates for mechanical thrombectomy if there's the amount of stroke or the amount of ischemic changes equals to aspect score above 2. To make it simple, is if the patient presented with an acute stroke symptom within 24 hours and the CT angio showed large vessel occlusion, you can actually perform thrombectomy even if the patient has ischemia on the brain CT scan. Okay? To get a better answer, you can do advanced imaging, such as CT perfusion. You want to see how much infarction there is in comparison to the penumbra. In the past, we used to say, well, if the stroke volume is bigger than the penumbra, we usually don't do thrombectomy. We only do thrombectomies when the penumbra is way bigger than the stroke volume. Nowadays, it's changed. You can actually do thrombectomies even if the stroke volume is bigger than the penumbra. Because this was tested in trials, and these patients with big strokes on CT perfusion, they did actually much better when they had mechanical thrombectomies in comparison to those treated medically in these trials. So nowadays, even if the patient has large stroke with some salvageable penumbra, we usually do mechanical thrombectomies. واضح؟ طيب, according to the recent guidelines, few things came up in the latest guidelines that was not there before in the 2018 guidelines. So for the first time, mechanical thrombectomy was approved for patients with big strokes on CT scan. Before that, we used to say, if the stroke volume is greater than the 1/3 of the MCA territory, we don't do thrombectomies. Nowadays, yes, you can. هذا واحد. اثنين, in patients with basilar artery occlusion. In the past, the guidelines did not talk about basilar artery occlusion, and it wasn't known whether it's beneficial or not. However, in the recent guidelines, now basilar artery mechanical thrombectomy is approved in patients presenting with basilar artery occlusion within 24 hours. 2. 3. Patient with medium vessel occlusion. Patient with not MCA M1 occlusion. No, patients with M2, M3 vessel occlusion. They can have mechanical thrombectomy as well. Number 4. For the first time, mechanical thrombectomies is approved for pediatric population. So in the recent January 2026 guideline, for the first time, the guidelines approved the mechanical thrombectomy in pediatric population. واضح? Any questions so far? طيب. طيب. After acute stroke treatment, whether the patient received IVTPA or mechanical thrombectomy, where does the patient usually go? Do we send the patient home? Do we admit the patient? And if we admitted the patient, where would the patient go? Okay, so usually after acute reperfusion therapy, whether it's IVTPA or mechanical thrombectomy, we usually admit the patient, Muhammad Atiyah. As the thrombolytics treatment, we use Actalase 50 milligram. True. طيب. بالنسبة للدوز of IVTPA, مو مهم تعرفوها. However, we use 0.1 milligram per kg. طيب. We use that 10% of this dose. طيب. We give it as a bolus and then 90% as an infusion over 1 hour. The maximum dose you can give total is 90 milligram. This is when it comes to TPA. طبعا the recent guidelines, tenecteplase, which is another IV thrombolytic therapy, is approved for the first time in treatment of acute stroke. However, we don't have it yet. We don't have it in our hospitals. And we use, in tenecteplase, we use 0.25 milligram per kg, and we use it as a single bolus. There's no infusion. And the advantage of tenecteplase over alteplase is that tenecteplase has a longer half-life. It's more fibrin sensitive, specific, عفوا. And because of that, the action of tenecteplase on the clot is actually longer, and the recanalization rate, theoretically speaking, is better than recanalization rate with alteplase. طيب. So after acute reperfusion therapy, we admit the patient to the ICU for 24 hours. And the main reason we do this, the main goal we admit the patient in the ICU is observation for clinical worsening. Because what's the most feared complication of reperfusion therapy? What's the most common or most feared complication of reperfusion therapy? hemorrhage. أحسنت علي، أحسنت يا ريمات. فإحنا أول 24 ساعة after the reperfusion therapy, we admit the patient usually to the stroke unit or ICU if the stroke unit is not available for monitoring. Any clinical worsening of the NIH stroke scale of 4 or more warrant a CT scan. بمعنى مريض was admitted to the ICU with a stroke scale of 10. Every hour you perform your NIH stroke scale. If the stroke scale in one of those assessment exams increased by 4 or more, يعني من 10 صار 14 أو أكثر, you stop the infusion and send the patient for an immediate CT scan to rule out hemorrhage. واضح؟ However, if the patient was stable throughout the 24 hours after the intervention, afterwards you can send the patient to the floor and try to manage two things. One, the complication of the acute stroke, and then start secondary prevention. Same secondary prevention we did in the TIA case. Exactly the same. طيب. We talked about the secondary prevention workup, but we haven't spoken about the acute stroke complications. So what complication could happen in acute stroke patients? What are the complications that we should pay attention to and manage? Any idea? Cerebral edema. أحسنت يا ريناد. Cerebral edema. This can be fatal. غيره. DVTs, PEs, urine infection, aspiration pneumonias, and so forth. Hemorrhagic transformation. أحسنت يا جوري. All these expected complication of acute ischemic strokes, and you have to think about it. Always, always, always. Seizure. أحسنت. أحسنت يا آلاء. Aspiration pneumonia. Excellent. واضح? So during the 3-4 days of admission after the acute treatment, you need to manage complications. At the same time, you can do your secondary stroke workup, secondary prevention workup. واضح? One of the things that you have to consider early on in the treatment of acute stroke after the hyperacute phase is physiotherapy. Physiotherapy is vital. Physiotherapy can change outcome if you started early versus late. واضح؟ طيب. This is basically if you guys understood what I said for the past 1 hour. If you understood what I said, I guarantee you that you can deal with stroke patients better than an ER or an ICU physician. Stroke management is not complicated. You just need to be thorough. That's it. Do you guys have any questions? Contraindication of thrombolysis. What's the way to differentiate? طبعا there's a list of absolute versus relative contraindications. من relative contraindication, someone who had GI bleed, for example. GI bleeding is not an absolute contraindication because you can transfuse blood and give TPA. Someone with myocardial infarction like 2 months ago, the risk of complication after giving TPA in patient with a recent myocardial infarction is not that great. However, if someone had a recent intracranial hemorrhage giving that patient TPA is going to put him at a great risk of having hemorrhagic conversion. There's no solid rule. I mean, it's a list, and you guys have to understand that these list of contraindication are not random. These are the contraindication that the initial trial used when they performed the study. The researcher decided that they don't want to involve these kind of patients because they thought that they are at risk of hemorrhagic conversion. That's why they did not involve all these patients. Okay, Renat تسأل, does fluctuation, deterioration, or less than 4 in IHSS, how to proceed then? طيب, you can, so if the deficit is mild, and not disabling, you can defer TPA. And the deficit mild versus severe is not dependent on the stroke scale only. بمعنى, the stroke scale can be 2, but the deficit is disabling. مثلا يجي واحد with pure language deficit. You can give him a language, stroke scale of 2. However, by number, it's less than 4. Like by impact, language deficit is major. So you should treat with IV thrombolytics. واضح? So we use both. We use the stroke scale itself, the number, and we use the type of symptoms the patient is complaining of. وضحت يا ريناد؟ محمد يقول, even if I'm a nurse, as a nurse I can gauge the doctor to the right direction. أحسنت. Any other questions? آية تقول, could you please send us the slides? أبشري. ريماس clear. فيصل, you're welcome فيصل. What's the indication to give low dose TPA? طبعا low dose TPA are off the records. I don't want to confuse you guys more than they already did. Some physicians actually sometimes uses low dose TPA in those patients who probably received a recent dose of anticoagulation, or if the patient has the time window is not clear. To be honest, I myself don't use low dose TPA. It's either I give TPA or I don't give TPA. I don't do 50% business. I know some physician would do it, but in my practice, I usually, if I think the patient needs TPA, then I'll give the full dose. If I think that the risk outweighs the benefit, then I don't give TPA. I just screen the patient for mechanical thrombectomy. Ali اسأل إذا كان if you don't have CT perfusion. طيب. Now the recent guidelines says you can use the CT scan alone to determine the risk or the volume of the infarction. We use the aspect score. In the recent guidelines, they don't even recommend using advanced imaging. You don't need to use CTP or MRI or nothing. Do your CT scan and CT angiogram. If the CT scan, the aspect score, or the volume of the infarct indicate that there's some tissue to be saved, you can proceed with mechanical thrombectomy. With IV thrombolytics, it's a different story because you don't want to facilitate hemorrhagic conversion. In thrombolytic therapy, if the MCA territory greater than 50% of the territory is infarcted, I wouldn't give TPA. However, I would screen the patient for the possibility of mechanical thrombectomy. طيب if you guys noticed, I didn't use the slide. I didn't go according to the slides. I just picked and choose which point I want to talk about. However, the slides are great. You can use it as a reference for vascular anatomy or general neuroanatomy, brainstem syndromes. You can use it. I tried to focus on the clinical aspect of the talk because I know it's going to take time. You can see that it's already 3 o'clock. And we only talked about probably like 5 or 6 slides. Ali يسأل, is there some indication or special cases for arterial TPA? طبعا, in the recent guidelines, it's actually recommended or it's reasonable to use intra-arterial TPA after mechanical thrombectomy because this could or may improve the functional outcome. Yani after you do your mechanical thrombectomy, you can inject intra-arterial TPA. It's reasonable. Before, we didn't know if it works or not. Shema, if the onset of stroke is in minutes, like in the hospital wards, fast access, shall we wait for 1 hour to check if it's TIA? No, you don't have to wait. You don't have to wait. As long as the patient has symptoms, you treat accordingly. It's actually not recommended to see if the patient improves or la. Even if you treat the patient with IV TPA, you don't wait for the improvement. If the patient has large vessel occlusion, you shift them directly for mechanical thrombectomy. واضح? No waiting, no waiting. Any other questions? جزاكم الله خير. Thank you so much for your interaction. I was glad to be here, and inshallah, يعني we'll try to arrange with Dr. Ali future talks بإذن الله. موفقين جميعا. شكرا.